Hello, thank you everybody for coming to our Innovative Discovery series. Prior to introducing Dr. Jeremy Axe, who just so happens to be my brother, I need to take care of a few housekeeping items. For CME credit, you must sign in and you must include your email and credentials. Do not miss our September 6th Tech Talk of Wei Chin from the University of Delaware. Also, please note, July 13th IB series will have a special guest, Dr. Susan Burkhoff from Christiana Health Systems, speaking on the usability and acceptability of a patient-centered mobile health tracking app among a sample of adult radiation oncology patients. Please register to help us prepare. And as always, the full schedule is posted on our website at DE-CTR.org. Okay, now to Dr. Axe. Dr. Jeremy Axe, a board-certified orthopedic surgeon, was born and raised right here in Delaware. He graduated at the University of Delaware and completed 4 years medical school at Thomas Jefferson University in Philadelphia. Dr. Axe did his orthopedic residency at Tufts University in Boston, Massachusetts, followed by an orthopedic sports fellowship at American Sports Medicine Institute in Birmingham, Alabama. He went on to complete a second fellowship back in Boston at Harvard, specializing in shoulder and elbow. After completing his fellowship training and additional studies in France and Switzerland, Dr. Axe returned to his home state to join the practice with his father, Dr. Michael Axe, at First State Orthopaedics. He has been in practice since 2015, specializing in shoulder and upper extremity surgery, joint replacement, general orthopedic care, and sports. Along with private practice, he also is currently a consultant on Christiana care for orthopedic trauma. In addition, Dr. Axe serves as a team doctor for various high schools and is also the orthopedic director of Health South Acute Rehab Center in Middletown, Delaware. Recently, for the first time, Dr. Axe was awarded the honor of Delaware Today's Top Doc 2017 and has been asked to sit on the National Orthopedic Research and Education Foundation. Without further ado, please join me in welcoming Dr. Axe to the Innovation Discovery Series.
Thank you everyone. Jill asked me a few months ago if I was going to talk, and I said, of course. Said Friday's work. I'm like, that's actually my best day. I'm running around the least amount during this day, but after this, I do have to go to cases around 30. So, as Michelle said, I'm from here, and my disclosures are here. I'm a Wright medical consultant. While I will speak to some of their products, there's several companies that do the same stuff, so I don't feel it has a big influence in my talk. And I'm from here, so I went to grade school, high school, and college here. And then I went to Jefferson Medical School, and then Boston, and then back to Birmingham with Dr. Andrews, and then back to Boston, and now I'm back here. And she just commented, one of my newer roles would be I was asked to sit for at least a 3-year term on the Orthopedic Research and Education Foundation. I'm part of their board of directors to help raise money and increase interest in collection of data in surgeons, why this talk is important to me. So what we're going to do today is we're going to talk a little bit about shoulder arthroplasty. Most people know about hip and knee arthroplasty. 95% or more of all arthroplastics performed in the United States is done in the hip and knee. Shoulder is kind of like the child that's left behind. No one really talks about it, but it's increasing. It's over 500% in the last several years, increasing in volume. So I'm going to tell you about what shoulder arthroplasty is, what I have regarding my research team, the process, patient updates, and why are we going to collect this data? Why is this important? So I'm going to give you a little brief overview of what types of shoulder arthroplasty exists. And the most common three types are a hemiarthroplasty, a total shoulder arthroplasty, and a reverse shoulder arthroplasty, or a reverse total. You can hear them all kind of synonymous to each other. So a hemiarthroplasty has limited use in 2018. Why we would use it if this is a patient of mine who came to me. He was incarcerated. He was involved in an altercation. His shoulder was dislocated out the back for several months. His cartilage on the inside, the glenoid of the shoulder, was relatively maintained, but his humeral head was destroyed and deformed. He's 37. To put a full shoulder, which I'll talk about in a minute, a total shoulder replacement in this patient would not be the best idea because they wear out. They wear out over time. And that's why we want to try to prevent revision surgery, because that's costly And by doing one surgery at one time, more beneficial for the patient. Now, he's 37. He will have additional surgery. He doesn't have much of an option. And given the deformity of his humeral head, the only option for him was a hemiarthroplasty. So I put a half shoulder in. So you can see here, on the side, the humeral side typically is talking about a hemiarthroplasty. Rarely.
You can't see anything.
You can just use the.
Oh.
Yeah, got it.
No.
Oh, that one.
Does that not show?
Oh.
Oh,
There you go. Okay.
So you have to tell me when you advance so I can
Oh, I'm
advance.
sorry.
Oh, that's what you meant.
You can't see that?
No,
I'm
she's
controlling
doing
it.
it differently.
I got you. Oh, I apologize. So this, you can see, he has a deformed humeral head. I'm like, all right, that makes more sense. Deformed humeral head. You can see here, he was posterior dislocated, and then we put a hemiarthroplasty, which shows just one half of the shoulder. Okay. We did not resurface the glenoid, which is the socket, because of his age and the possibility that he still has cartilage there, and he's going to need additional surgery. Why else would you do a hemiarthroplasty? Avascular necrosis that only affects the humerus, some fracture work, but that's pretty much it. Or someone that's extremely young, like this gentleman. So, what's a total shoulder arthroplasty? It's indicated for end-stage osteoarthritis when there is no cartilage between the glenoid and the humerus. So we resurface both the inside, which is the socket, which is the glenoid, and the humeral head, which is here. So these implants happen to be stemless. There are multiple different types. There's ones with stems or without. But the process is still the same. Both surfaces are resurfaced. Next is a reverse shoulder arthroplasty. So this is what came into America in the mid-2000s, and it's been done in Europe for over 20 to 30 years. But what it's for typically is patients with arthritis that have rotator cuff tears. Typically, when you have a bad rotator cuff tear with arthritis, you can't do the normal resurfacing that I just talked about. You have to change the mechanics of the shoulder because the rotator cuff is no longer attached. And we know if we try to fix them in the same setting, it won't work. Also, if you have severe deformities of the glenoid, of the socket, or the bone of the humerus, that may be an issue. And then also, I don't know if you've ever heard of, it's called reverse force fracture, which is a proximal humerus fracture that is so bad that it cannot be reconstructed. And we know that in typically the elderly population, 70s, 90s, they do better with this type of replacement, in which the ball is now on the socket side and the socket's now on the ball side, so it's technically flipped or reversed. So who performs these? General orthopedic surgeons, sports trained orthopedic surgeons, which I am, shoulder elbow trained orthopedic surgeons, which I am, trauma trained orthopedic surgeons, which I'm not, formally trained in trauma, even though I do take trauma call, and then arthroplasty trained hip and knee surgeons. Like I said before, a lot of these people, almost all the arthroplasties in America are done for hip and knee. However, there's about 5%, which is growing, for shoulder. But who should do these cases? So when we looked at early comparison of learning curves. So it makes more sense. The more you do, the better you're going to be. Now we know that from this study and from other studies that you need at least 15, 20, sometimes 25 shoulder arthroplasties to be competent and to maintain that skill per year. They found that for this case, in this series, that 16 was enough for a total shoulder arthroplasty to be competent. I don't know if that's enough. That wasn't what we talk about in our private meetings. We say usually about 25. But more importantly, the fact for a reverse shoulder, which is a newer process and a newer thing that we're learning about every time, they think they need at least 100, which is a lot, 100 cases to be really competent at doing this. So higher volume surgeons do better, but we still need to continue to observe. We still need to go to our courses. I just got back from San Diego Shoulder Institute course last week, and I learned more there than I thought I would, given the fact I'm only 3 years out of practice. I trained at Harvard. I trained in France and Switzerland. What else can they teach me? No, we still learn every single time. I go to a new especially to this conference, to other conferences as well. But this article really highlights the fact that we always have to be continuing our education as students. Next slide. Over 80% of our arthroplasty, around 90%, is done by surgeons that do less than 10 a year. That's kind of scary, right? So we think, in our expert opinion from my societies, but also from some of the literature, maybe more than 16. I think 25 or more a year. Arthroplasties need to perform to maintain that skill. Something that it's not easy. You don't have to set up. You need a team that understands it. A lot of things go together. And say you don't have a team member that you usually have, that shouldn't make it change what you need to do. So you have to be able to have the ability to have the experience, figure out what to do next. So how do we plan a shoulder surgery? You just go into the operating room, say, oh, put the x-rays up there, and say, oh, that's about right, and it'll be good. No, what we really do, at least what I've been taught, 2D x-rays, they're not reliable. You have one x-ray tech take an x-ray, and have another x-ray tech take an x-ray, and they can be of the same view, but completely different. They can show you two grossly different deformities. One that looks, oh, that's not bad at all, versus one say, oh my gosh, it's more than I thought. Versus then we've looked at CT scans. So two-dimensional reformats of CT scans. That has improved our reliability. And if you don't have the ability to do the next part, it's definitely what's required, at least for me, is a CT scan to evaluate certain measures, which we'll talk about in a few minutes. But they can also be misinterpreted because a 2D image can be looked in one plane for one thing, and then you scroll down, especially if you're doing an axial cut, which goes straight through the body, you can see a different deformity that you missed completely because you didn't scroll down or scroll up enough. So what's the real one? The 3D CT. So the CD, it's a CT that's done with 3D recons, but we have the ability now in 2018 or as early as 2014 in America is to place the CT in a special program free of charge to reconstruct the shoulder joint and give you a three-dimensional observation of what's going on regarding certain measures in the shoulder, not two-dimensional, three-dimensional. And I think it's the most reliable option that we have without additional cost or radiation to the patient, because in 2018, if you're doing a shoulder replacement, it is highly suggested, and I think mandatory, to get a CT scan at the least to evaluate the glenoid morphology, which is the socket. So this is an example, and I am a consultant for this company, but there are many companies with the same product. It's Wright Medical. They developed a three-dimensional process, a three-dimensional program that you take your CT, you import the DICOMs, and all of a sudden, this couple minutes, this three-dimensional thing comes out, and I'll show you in a minute. There are multiple versions that have been introduced. The most current was this 1.1.4, but it was made in 2014. I've been using it since I was a fellow. My fellowship director was one of the creators of it, so I've been, since its infancy, I've seen different derivations, iterations of it over time. And the best part, any CT scan can do it, anywhere in the country. All you need to do is certain parameters. It requires just a few more little clicks for them, but really nothing, and Christiana does it for me along with some other local companies. The capabilities, so you're able to assess the version and inclination of the glenoid. The humerus, that's not that big of a deal. Most of our deformities we can get, it's nice to have the 3D images, but the glenoid is where we know the failures are. Over 90 to 95% of failures come on the glenoid side, regardless of what replacement you do, whether it's a reverse or a total. So the humeral side, as long as you're pretty confident in putting in certain implants, you should be okay with that three-dimensional plane. It's the glenoid that's the key. So it allows me to three-dimensionally plan for my total shoulders and reverse shoulders, and it includes all sorts of glenoid augments if I have to do certain special procedures for really bad arthritis, all the humeral stems, everything else, and I have the ability to make a three-dimensional guide, which can decrease my ability to have to guess in the operating room, because our whole goal, again, remember, value-based is to decrease revisions with decreased cost of the system. So this is one of our major journals, JBJS, automated three-dimensional measurement of glenoid version, inclination arthritic shoulders. So the lead author, Pascal Below, I did not train with, but the senior author is Gilles Walsh, who I did train with in Lyon, France. And essentially, this is their program. They validated it. They found that it works extremely well, especially compared to X-rays. And then when you compare it to two-dimensional images, what it does is it eliminates intra and intra-observer discrepancies. So again, if I look at a 2D image on a CT scan, now CT scans are pretty much the same regarding what they are, not taking like an X-ray tech taking two different ones. But a CT scan looking on a two-dimensional program, if I look at it and my colleague looks at it, we may get different numbers for inclination. But given this, the three-dimensional image, that's what you get. The algorithm behind it's amazing. I've actually seen it once. It's like literally a wall of just numbers that I don't understand. But it gets away from that inter and intra observer discrepancy. So the influence of doing this also makes a big deal. So it allows us with these three-dimensional images to plan pre-operatively to know exactly what we're going to do post-operatively or intra-operatively. So I pre-operative plan every one of my cases for shoulder arthroplasty with a 3D planning tool. So I perform more shoulder arthroplasties than anyone else in Delaware. I perform approximately 100 per year. And that number is growing as my referral basis improves. I create three-dimensional guides for all my total shoulder patients and for many of my reverse shoulder patients. And why? Because I'm not better than a computer. I'm not. My eyes aren't better. My hands aren't better. Computers let us know I mean, they can give us exact numbers. So if you look at this guide, so and I'll show you how we plan one case or two cases. But this is a glenoid representation, and this is a guide. You have to put a pin in the center of that glenoid in 3 dimensions. Try doing that with a patient who's breathing or not breathing, depending on if they're intubated or not, whether they're bleeding or not, whether they're tight or not, whether they're a 300-pound former linebacker or not. And you try to get that in there without a help. And to me, that doesn't make sense in 2018. 2010, when we didn't have this technology, I understand, do your best. But yes.
Like functionally, how do you actually get to the shoulder? Like that part is really hidden. How do you?
Right.
Where
So
do you cut? How do
for
you
most of us, we do a delta pectoral approach. So the deltoid's on one side, the cephalic vein runs between, the pectoralis major on the other side, and we spread that interval. So it's a muscle sparing technique to get to the joints. And then if you're going to do, most people, about say 95% of people will take down subscapularis, which is the front muscle to the shoulder, and expose the humerus and the glenoid. Which I do for most of my cases. Very rarely, some people can go laterally for other techniques, but for a shoulder replacement, that's the most common. So I'm going to show an example. This is a total shoulder example. A 52-year-old male with end-stage arthritis of the shoulder. He failed conservative management. That's important. Usually you have to fail conservative management to include physical therapy, injections, activity modification. So hey, the guy's bench pressing 300 pounds. Why not do 185? Go back to cardio. Get your heart better. You don't have to bench press 300 pounds anymore. I do get an MRI in my total shoulder planning cases because they need a rotator cuff. Need that to succeed. If you don't have that, you will not succeed. And then I 3-dimensionally plan the case. Next slide. So this is the gentleman. He has end-stage arthritis of his shoulder. He has a little bit of wear. So this is the front. This is the back. So anterior, posterior. And the humeral head is a picture within a picture, but you can see it right there.
Can you point out?
We can't.
Nobody has that.
It's hers.
It's
Oh,
So you
sorry.
can-
So,
Can the computer not go?
so humeral head's here and it's going out the back there. So this is anterior, this is posterior. That makes it a little more difficult.
You can't point out those landmarks right
Yeah.
So next slide, this will help a little bit more. So this shows us, 19 degrees of retroversion, okay? Average is 7. So this patient's 12 degrees over. Superior inclination, we never really looked at that before. That's another 2-dimensional image that no one paid attention to until 2014. We found that if it's more than 10, if you correct more than 10, then you have a higher risk of failure. So you want to keep that number under 10. And posterior humeral subluxation is also important because if that number exceeds 80%, their likelihood of failing a total shoulder replacement increases. So 3-dimensionally, I get to plan this. This is kind of fun. I get to do it between patients. It's actually like me playing video games at 36. So I get to really plan what I want to do. And I want to get this to seat 100%. I want to have this nice implant that it's put in. And you can see, because he was coming out the back, there's a little bit of an augment that's put right there, the back of the glenoid. That's going to center his humeral head because that's extremely important. You get to show the humeral head. You get to see what size you want. Again, I get relative indications of what sizes I want for my implants, so that I can also decrease the inventory that needs to be brought into the room. All the other, saving if you're going to do these in outpatient centers, decreasing the amount of trays you need, those kind of things. And then you show the deformity in the bottom of the humerus that needs to be removed, or that right below the blue or the teal. And then when it sits now, the humeral head's completely centered, right in the middle. So that's what I want to create. And next slide. You'll see my 3-dimensional guide. So you take 4 points in the glenoid, and they make a little guide for you. Now, this used to be made in France, and then had to come through customs, all this fun stuff. Now, they're going to be made in America, which is great. So next month, they're going to be made in Minnesota, and so we don't have to go through customs anymore, and the turnover time is going to be 2 weeks as opposed to 4 weeks. And then you get my head center where I wanted it. So exactly where I wanted to be. This was actually planned perfectly from what I planned to what was put in, which is about 85% of the time. Sometimes the humeral head may get smaller, but the glenoid, the socket part, which is the most important part, because that's what fails when we put it in the wrong way, was perfect. So next slide is this is an example of reverse refraction, reverse shoulder replacement. He had rotator cuff tear, he had arthritis, so he does not get a total, he gets a reverse. So again, he failed the 3 things: activity modifications, PT, and injections, and he's like, I can't do this anymore. So he does not need an MRI. I already know his rotator cuff is torn, and I'll show you why in the X-ray next. And I 3-dimensionally planned surgery. Next slide. So you can see here is, unlike the other gentleman, his humeral head starting to migrate up. And if that migrates up, that means what was occupying that space, the superior rotator cuff, is no longer there. And when it's no longer there, then we can't fix it. So what we do is a reverse shoulder replacement for him. He's 72. The average lifespan for these in Europe are about 15 to 20 years now. So we've been very happy with their long-term outcome. And besides, he's miserable. He's like, I don't want to live like this. I can't move my arm. I'm very unhappy. Most of them present with pseudo-paralysis, which means they can't lift their arm above. Some people define it 90, but most people define 60 degrees, mid-range body. They can't get to the back of their head. They can only get to their mouth, and they're in pain. And imagine that bone is rubbing on that bone, and it just hurts every time they move, turn over in bed, etc. Next slide. So his retroversion wasn't terrible. Only 16, only about 9 from, or 10, 9 from normal. And then his superior inclination wasn't bad. And his humeral head was relatively centered, but was going up. So again, no rotator cuff. Slide. So this is you put a base plate with a sphere. So it's essentially a base plate, which is it screws into the glenoid with multiple different ways with different companies, and then you put a ball on it. That ball is secured to the base plate. It's all secured with screws. Much more stable configuration than a shoulder replacement because that's usually a piece of plastic that's cemented in. This is metal and screws. So this also has a little bit more forgiving regarding how much you can be off the axis. We try to implant these in at less than 5 degrees of retroversion and no inclination. And sometimes, because of that, this patient needed an augment in the back of the shoulder of the bone because otherwise, if I tried to put that in, this would be going in the wrong plane and the screw would actually blow the glenoid up. So this company does have augments along with many other companies to make us as surgeons look better in the end. Next slide. And this, you see the socket is now on the humerus versus glenoid side. So that ball will articulate with the socket that's there. And then next slide. And you see this is the plan, what's supposed to look like. Now, it may look like the distance between the acromion, which is the outside of your shoulder, and the top of the humerus is increased. Exactly, because we need to put stretch on that deltoid muscle for it to function as almost like a rotator cuff. Now, are the functions the same after a total versus reverse? I don't tell patients that. Some of them are, because they're amazing compensators, but mostly total shoulder replacement, let's say you're going to be about 170 degrees back here and pretty much behind your back. For reverses, I say 120 degrees, side of your head, back of your head, and the side of your bum, because internal rotation is significantly lacking, and the prosthesis itself can't get you typically above 120. Now, 20% of people have that gift. We don't know why they do. We can't describe why they do, but typically it's most likely from them having chronic rotator cuff tears with bad pain, but still pre-operatively they can get their arm up, and they want that pain to go away. So next slide, and this is what we created, and it looks great. So he's very happy, and the same thing he can get. He's about 140 kind of guy, which is nice, and everyone's happy. He's like, "You want, Doc, you still want to get here?" I'm like, "Well, if you get here, it's gravy." So you get there, I'm happy. And I have some people can go all the way up, farther than I can even get up with the normal shoulder. Next slide. So how do we know when we're doing a good job? This is why I'm here for you guys now. Is the collection of the data is the key. We must be able to compare our outcomes to the region, whether it's in Christiana, whether it's with Jefferson, Hopkins, around nation, all the way to maybe UCLA, and maybe the world with my French colleagues. And how do I employ this in private practice? So I got this from my father, which is a little different than most people's thinking in private practice. I employed my own research assistant, which is similar to my fellowship director. While he was a Harvard professor, Harvard surgeon, he was still in a private practice model there. And you pretty much worked for yourself. So he employed his own research assistant, didn't receive any funding from MGH or anyone else. So I employ my own research assistant, and I use a program called SOS, which is Surgical Outcome System. One of the big companies developed it. There are many out there. OBIRD is one that you may have heard before. They are the tracking systems. So my RA, what I look for is a young professional post-college who's pursuing an advanced degree, usually 22 to 25 years old. They work with me when I'm in the office hours. And if they can't make office hours, whether they have another class, maybe they get a master's or something else at this time, appointments, make a list of the patients that they have to contact after my office hours. They work solo for collection of data at peak times. So for instance, early evenings, if you don't get that data point, my research assistant will call patients at their home from 5 to 7, the ones they need to get. Not many, but she does call them. And it costs me about $15,000 a year of my own money to have this done. They're a 1099 consultant. And the best part is they work under the insurance plan of the parents. So their S contract, it's really easy for me. Minimal paperwork. I don't have to worry about anything regarding that. And that's why 25 is a good number. 22 when you get a 26-year-old, you got a little problem. But also they have that. They also, the 22-year-olds have this, like, want to do something. They're going to advance. So both of mine are, my one just matriculated to PA school, and this one's going to go to PA school. I recommend aspiring PA students because this is what they want to do. It's a good gig. They don't have to work when I'm working in the office, and when I'm operating, if they don't have to collect anything, they're off. So when I'm off, they're off, which is nice. So I already got a full week off last week. And I'm currently on my second RA now. I'm in about 9 months in the collection. So the process, when the patient decides to proceed for surgery, now, I'm only doing shoulder surgery collections at this time. I want to start playing with that, even though I do a fair amount of trauma and knee surgery and elbow surgery. But right now we're just tracking my shoulders because that's really my passion. So after I talk to the patient, we like to proceed with surgery. So my research assistant will come in the room, and then she'll discuss the benefits of tracking their progress. Every patient has the right to say no. We've only had one, and a couple hundred, or now we're 300 that have said yes. And how it works how it helps both me and the patient and society eventually. And there's 8 to 11 survey points throughout the time. It depends on what type of surgery. So the research assistant monitors the progress and will provide the patients with updates every time. And at 3 months, they'll get your score compared to different things. So say you are a Medicaid smoker, you'll get your report compared to norms, and then my norms, and then you compare it to the Medicaid smoker and see where you're at regarding that level. Or patients with your same BMI classification, or same other things that you can look at. Same thing with work comp and auto. So you can parcel these out because not all groups cover the same as we know. So next slide. So this is just kind of what we look at, just data collection points, pre-op, 2 weeks, 4 weeks, 4 to 6 weeks, 3 months, 6 months, 1 year. And then depending on what type of thing, I'll check my arthroplasties every year afterwards. After that, for rotator cuffs, typically once you get to the 2-year mark, we're done with you. Regarding surveys, sometimes even with, I don't even bring them back. We may bring them back. We can decide at 2-year mark for rotator cuffs to decide, but if they're doing well, usually they don't want to come back. But we still have their emails and their phone numbers, which makes it easiest for us to ask them to fill out a survey. So next slide. So what we enter the BMI, find if they're a diabetic and they're Medicare or Medicaid, if they're a smoker, workman's comp, and if they have pre-operative use of narcotics, found to be an important one too. Next slide. So this is pretty cool. So you can pretty much put in everything. So every person I do gets right which side they which side is the treatment side, dominance, hand dominance, what the diagnosis is, and she listed them all here for me. It doesn't usually look this jumbled and looks like all that, but it's much smaller. But she put every single diagnosis, most things, what implants I use for my surgery. So we can even parcel out if I use this type of implant, did I have a higher failure if I use this type of implant? The same exact problem. Say rotator cuff repair, we change implants we use, not often, but occasionally for different things. And we can figure out what type of implants may work better or worse, or are they the same. You can even go to as what surgical dressing you put on. Did you put a silver line dressing? Did you put an occlusive dressing? Did you use Dermabond, which is a sterile super glue? Did you use any of those, or even just staples? So we also put their ICD-10 codes in along with the CPT codes. So every dictation I have, if anyone's ever seen them, they all come with their CPT codes because I think it's important for multiple reasons, but more importantly for billing to know what codes and for tracking. So billing and tracking. So now I've done it since I started. I started in practice, which I was taught at my Harvard fellowship to always have these down. Most important for billing and tracking. So you can always track these whenever you want. You want to pull up the CPT code, how many you did this number, or how many you need for this surgery or for this study. And then the ICD-10 code they usually look up because it's listed in my diagnosis. The ICD-10 codes are just, I can't remember, M752.16. Like, I'm not going to remember those, but the other ones are very, very common and I use every single day. Slide. So how to maintain compliance. Right now, we are the most compliant of this system in the country, and it's ridiculous because most people are about 67%. We're at 98 for shoulder arthroplasty and 97% for shoulder arthroscopy. And the average is, or I said, 67 and 63, which is still considered decent. That's considered decent. So, everyone wants to be over 80, but we're at 98%, 97%, and they've actually the company's come to us and talked to my first research assistant on how the heck she made this so good. And she came up with a handbook. My now research assistant has another handbook, our maintenance of this level of compliance handbook. We've been doing well. So and back then, at that point, we had 77 enrolled in arthroplasty and 236 enrolled for shoulder arthroscopy, which puts me around over 300 arthroscopies in about for shoulder and arthroplasty shoulder arthroscopy in around 9 months, which is a pretty high amount for shoulder surgeons. So there's a variety of ways to get responses. So sometimes they come in the office, they didn't fill out their survey. We can fill it out right then. All right. We bring a little tablet in. Here, take 2 minutes. Dr. X will be in a few minutes. Here you go. Fill it out really quick. So my RA will go in without me even knowing. The best part, all this happens without me even seeing. Like I'm running around like a madman. This happens without me even noticing. My RA doesn't take any of my time. I've never found any issues with it. So anyone that says that be an issue, they're just giving an excuse, or they just need IRAs, which they can't have. So, you can also have we tell a lot of patients, hey, if you're going to wait in the waiting room, while my waiting time is not long. So sometimes it can get there, but they can do it on their phone. It's very mobile accessible. You can call on the phones those sweet times, the 5 p.m. to 7 p.m. Usually doesn't offend too many people to call up to 7 o'clock, especially our older patients. You can get them on a phone call, and they can do a verbal one on the phone. Emails also work, and then there's patient portal that can be accessible. Next slide. So what do we give to the patient? We give them a brochure about what the SOS surgical outcome systems is. We give them a graph of my averages, or whoever's doctor's averages for the operation. This is the day that they sign up. A research information sheet, and the most important part, the HIPAA and IRB consent. So every single person has that. It's scanned in our computer system, and it stays there. Next slide. So this is what it looks like. Side left is the research participation information sheet. Top is what people progress with a certain surgery. The bottom is what it's one of the pamphlets they have in the brochure, and the right is their HIPAA form or their authorization. Next slide. So patient updates. They're more inclined to participate if they get something in return or see their progress. Because they can't log into the system, they're not allowed to see it, so they understand that part. What we do is at that 3-month mark, we give them the pamphlet. Look, this is how great you're doing. Or, hey, what's going on? There's something not clicking here. There's something else you need to look at. You need an injection, and we document all that. Patient at 3 months still having some inflammation, needs an injection. They're tracking from there. So, but they really do like to know that they're being tracked, that they matter, that they are being compared. And some patients get a little competitive with, and they're like, oh, okay, I'm doing good. I'm really good. Or they think they're like, this is like, especially like ultra competitive people to begin with. They think they're like, I'm so far behind. And you show them like, listen, you're about the standard deviation above normal. So we probably need to pump our brakes as opposed to going harder. You may hurt yourself and get inflamed. Next slide. So this is just an example of what they'll get at 3 months. They'll have them versus me versus global, and for pain, this is just pain and function scores. And then on the right is what we've been doing. We've been manually doing this for a lot of our patients because the program doesn't do this yet or just started to because they stole our idea. My RA's idea is to put in the range of motion. So we know they're passive and active for these certain things. When you show them that, you can say, oh, you're doing pretty darn good for most of these, or what you progressed. So this one's just showing from February to March how much better your forward flexion is, how much better your active range of motion is. So that they really like to see that. Slide. So what have we learned? Many patients really do want to know how I and my other colleagues compare to the global standards. Do I have a good surgeon? Did I choose the right person? Many patients know they're compared to other patients. Like, not only did I choose the right guy or girl, how am I doing compared to other people? Like, they get a little bit competitive with that sometimes. And they want to know what the trajectory is. Like, so am I expected to have pain at 3 months from a rotator cuff? Yes, you are. You're going to have pain. But, well, when you're going to usually have about this much pain. Like, oh, that's about where I'm at. Or, I'm not like that. That's great. Or, I have a little bit more. And when we have a little bit more, then we have to look at a few factors. Did you have pre-operative use of narcotics? Are you a smoker? Are you diabetic? Could there be a non-healing tendon? Could be a delayed healing tendon. Could be a retorn tendon. Those kind of things that we have to look for. And most of them don't mind being part of the study at all. They just don't want a time commitment, and it's really minimal. It's like 2 minutes, 2 to 3 minutes, because we put all the stuff in the computer ourselves to begin with. It's a quick survey, and they're done. It really doesn't take that much time. And having them be asked by my assistant really does increase the compliance. So if they're not in, if they're coming in for their 2-week follow-up and they didn't fill it out that day or the day before, we get them in right then. Like, hey, please fill this out right now. So after 9 months, again, this is really early for me, and I wanted to just establish my practice and kind of get this down, and then before I wanted to incur decent cost to me, while I think it's extremely important and needed, it's still a cost that, especially young surgeons saying, hey, you're going to pay $15,000 out of your pocket to get this done. And you're like, what? I don't want to do that. So it took me about 2 years to say, okay, let's get this done. So I took. In the 9 months that we've collected thus far, we found the trends to be what we expect. Smokers, workman comp, auto accidents, Medicaid, they have higher pain and lower function at 3 months for all surgeries. I mean, across the board, which is normal. And then we found that men typically do a little worse than women. BMIs, as you get bigger, they do worse as well. And then diabetics, healing is less good. Also notable findings: pre-op narcotic usage correlated with greater pain and lower function. That is just something. So I mean, we know that to be true, but now we are putting out publications about, hey, we can get you down on your narcotics before. Even as patients, same thing with smoking. If you can smoke less for me, you're not going to get someone to quit. It's just not going to happen. Rarely. But if you ask them to smoke just a little, you can go from half a pack to half a pack. That still increases your ability to heal. So if we can even decrease their narcotic usage before surgery, hopefully post-operatively their narcotic usage can be decreased as well. And we found the biggest group of complainers are the 41 to 60-year-olds, which are our laborers. They're our laborers. They're the ones that are still working really hard. They're the ones, the 25 to 30 to 40-year-olds really haven't gotten that rotator cuff tear yet. Typically not. And after 60, usually they've moved on to either a managerial role. They may still have a rotator cuff, but they're not pushing and pulling all day long, 10, 12 hours a day, really beating their biceps. So we found that sweet spot of pain is that 41 to 60-year-old, which makes sense, especially in our laboring population. Next slide. So every month I get this email from my research assistant, and this will be updated 6/16 of this month. And this shows you how many arthroplasties we've done in the last 9 months. For shoulders, I've done 270. Again, this one was this point because that was the last month I showed you before. 91 arthroplasties. So in 9 months, we're almost 360 shoulder surgeries, and showing the most of my said like hemiarthroplasty is rarely used. So if you look at my arthroplasty total, 54 versus 34 were regular or totals, and then 2 hemiarthroplasties. And one was that gentleman that I showed you that was incarcerated and now is doing quite well. Next slide. And this is what I get to look at. So they can tell me my work comp, how I compare, function, pain, function, smoking, Medicaid, pain, function. And you look at all these, and it's like, okay, it makes sense that the people with the work comp, with the smoking and the Medicaid are all higher than my globals for the most part. Next slide. And then BMI, you can also look at narcotics and male versus female, and I just talked about. Next slide. Age and diabetes. And again, you see there are differences from all of them. I know it's all quite small, but this is what we're doing now. But this is my bigger one. So this is if you look at this is like for reverse shoulder replacement. And most people are doing well in that bottom line. But if you look at the 3, the smoker, the Medicaid, and the auto, they just go up at 6 weeks. And the reason why, they're getting out of their sling. So they get out of my reversers are staying in the sling till the 6 week mark, and then all the pain goes up. Now they have to do something that they haven't done or didn't want to do the last 6 weeks. And you see everyone else keeps trending down. Yes, sir.
How do you know these patients are smokers?
Oh, we asked them.
You don't test them, just ask.
We don't test them. And to be honest, most smokers that smoke, that probably will cause a difference, you can tell. You smell it, and they comment. I mean, I had a patient, I'm not going to lie, a patient yesterday came in, she had a reverse shoulder replacement, and she had a cigarette in her hand and a lighter on her way out the door. I mean, most of these patients are addicted. And you're right, you may be missing a few. But nowadays, people they're pretty upfront about it. Narcotic usage, we can do a PMP. We can query them and see if they've gotten narcotics legally before. In Delaware, which does 37 states now, that we can look at and see where they've gotten their narcotics from legally. But for smoking, it's a trust thing. But I don't think I may missed a few, but those few are they probably smoke maybe a cigarette here or there. That probably won't change too much.
What's the gray? Because your picture's blonde.
Oh, it's the gray?
Yeah.
Dominant side. Gray is dominant side.
And then if someone was a smoker and then they quit, like either in that pre-treatment at 2 weeks or thereafter, you end up changing?
No, they're going to be way before,
Okay.
several months to a year before, because you're still going to have the post-operative complications of smoking.
And where are they included if they're multiple? Like they have Medicare and they are smokers.
You can do that. You can do
You do.
tables for that.
You put them in both.
So they're in both, but you can also do a table that look at all those together, all 4 values. You can just choose what value you want to put together. Show you compared norms. Next slide. So what's in it for patients? Again, they want to know how their doctor performs compared to the average. They want peace of mind that they're doing well. Or maybe they can validate that they're pain. I'm supposed to have pain at 3 months from a rotator cuff. Yes, you are. And then you can look at how they tracked based on certain demographics and how they've been engaged in the process. They like being engaged. They like, we live in a society now that we have to turn to patients to make things work, to pay bills and do other things, and they like that extra part that a lot of those surgeons don't give them. It's another touch point with them that make them feel better about their progress. So next slide. So what's in it for me? I can see the trends in the demographics. I can see which patients I'm going to possibly not do well on, and maybe not beat myself up. I beat myself up a lot when I don't have a good or great outcome. And sometimes, and I've learned this over the last couple of years, that you're not going to be perfect. You're not going to get the perfect result every single time, even though I think I should. I demand that excellence from myself. You're not going to get that. And sometimes you can make yourself sleep a little bit better when you know that, at least you did your best job possible, but you're maybe fighting an uphill battle. And maybe they're not going to get to that spectacular moment, but they got a lot better than they were, even though they still may complain. But you can look and say, listen, I know where you were before, and I know where you are now. Pain's a little bit better, not 100% gone, but your function's better, and you're better off from this surgery. And then I can compare my averages, and then it is a way of keeping track of my results. So what if I change something? What if I use a different prosthesis, or I use a different implant, and all of a sudden something goes down or something goes up? Well, that's a big deal. So maybe we can say that, and we can then parcel them out too. That's why it's so important. Every dictation I have, I put the exact implant that I put in to always track what we're doing. Next slide. So what's in it for everyone else besides for the doctor and the patient? So the data can be released, if you choose, depending on the company you use, to the general public. So patients do physician shopping. We know they do. Maybe some of you do too. But you can go to 2 or 3 different surgeons or doctors for a different opinion and figure out which one you like or which one you think is most substantiated. But they don't always have to go to primary care doctors now, and they can use urgent cares for referrals, which is a real new big thing. Companies can use this data also to determine what alliances they have. So there's big companies now that are determining, we're going to only send our patients to certain places because we know their outcomes are good because they've been tracking them. We're not going to take a roll of dice and say, oh, you can go to him over there. I heard he's good, but we don't really know. And then journals, and especially data registries, may benefit as well from this pool of data. So traditional uses of research. Doctors you can use to track their own procedures, own processing procedures, and we can use this data to do that. We can also use it to publish. Now, it typically needs 2 years of follow-up to get published in any major orthopedic journal. Thanks, but you need 2 years to really be considered to have a level 1 publication. We can use it for teaching. So we can use it to teach other surgeons, teach physical therapists, which I do a fair amount of, teach students, and then maybe get published in the JBJS, which is really nice. Well, what else we can new ways to use this research is to help patients be more oriented, be more active in their care, like we talked about. Referral patterns now. So larger companies are going to start looking at outcomes, or have started looking at outcomes, to say where they're going to send their patients to. And it's recommended now, the Agency for Healthcare Research and Quality now are looking at individual physicians' numbers to globalize a whole group. So if you're going to put that out there, if you have a couple of surgeons that are publicizing their numbers, that whole group may get like an A rating, which would be nice, but you still need the people to do it. And they do recommend mediating for risk factors and risk adjustments for diabetes, work comp, narcotic use, and smoking that we just talked about. Next one. So the traditional ways of referrals that we all know about, word of mouth, experiences, availability of insurances, and even online shopping. But that's going to start getting taken over now by next slide. Why is that transitioning? Is because we need to cut down the visits. We have too many visits in America for medical problems. So if we can try to provide the best medical treatment, the least amount of visits, we can avoid this overcrowding phenomenon that exists now. And urgent care is now becoming the more popular scene to go to. Wait times are less. You can go whenever you want. And the next slide, they're becoming drastically more popular. We had 400 more last year than we did the year before, 16 to 17. And the volume rate is 1,700% more in 2007 than 2016, which is only 7 times the growth in the ERs. Thus, they're really using these urgent cares as primary care doctors. And as a result, since they're taking this role, what their job is, they're like an ER doctor. They're turning and burning. They need the patient in, out, with a diagnosis, next level. And the next level is, where are they going to go? So now they're finding new ways to refer refer the patient to the next level while not decreasing their efficiency. So what factors ability to do that? Next slide. They're using these referral systems. So a lot of the places now have their own referral systems that generate referrals to a patient for patients without primary care doctor. So they have these systems that already have clinical input from patients before satisfaction scores. They already have the required numbers. Like these are already done things from providers that have been approved by this e-referral system. And it can be placed in advantage if you're one of those referral doctors. It's already in the system because you've already tracked your data. You're already available. And you're there for people to the next level. And so the e-referral system is a trademark system that's used by many urgent care centers. But orthopedics, besides for MRI, is the number one specialty. So MRI is really not a specialty, but number one specialty that's used from this e-referral system. So I mean, look at the amount of volume per month, 250 referrals in this, average per center per month, which is a significant amount. And that was only in 2012. It's just, I mean, we're in 2018. We just saw the growth from 6 to 17 was 1,700%. So you can just imagine those numbers being more and more every day. Next slide. So the Employee Center for Excellence Network was launched in 2014, and what's used by is like Walmart, Lowe's, McKesson, which is a major medical company, even JetBlue, one of our large airlines. What it does is bases the so based upon outcomes at the surgeon level is what they'll allow their patients to go to. I mean, they're their gatekeepers. So if you get hurt on the job, and it is state dependent on certain laws, especially in Pennsylvania, they can determine where you go, especially for the first 90 days. Delaware doesn't have that law yet, but it could come. And we saw this in Boston. We were the provider for American and now US Air, now American. So we saw a lot of jet pilots that had, or even people moving the bags. So we had a lot of rotator cuffs from that. But my surgeons were the provider part because they've been tracking their data since 2010, or even before, even in a much more archaic way, but now a much more systematic way with SOS. And in order to qualify, your patient outcomes must be provided. And even be a joint surgeon for this, which is even the list is just about 30 different points. They come and they do site visits. They come and look at your hospital. They look at everything to make sure you're a center of excellence. While Christiana is a joint center of excellence, I don't know if it's a center of excellence regarding any of these major companies yet. I'm sure we could be. Absolutely. We have one of the best infection rates, length of stays, and everything else. But I don't know if we hit this level yet. But if we could secure that level, it'd be nice. So again, Walmart is one of the biggest companies that's doing this. And the goal is to get their patients to return back to work the fastest, because every day out is costing them money without getting a revision. So that's the most important part. You want a surgeon that does a very good job, revision infection rate is low, and get them back to work as fast as possible with a great outcome. Because a revision surgery can cost a significant amount of money to the system, along to the patient, and more importantly for them, to their company. If they're out of work for a typical total knee replacement, depending on what they do, so you work at Walmart, you're walking the floors, maybe 90 days, maybe 120 days. But if you have a revision, because you have an infection, now you're looking at 6 months to a year. So that's a whole year of work that patient has lost to do. But more important, that company has lost a whole person for a year, but they still have to pay for it, which is a big thing. So in summary, that is important to keep our patients engaged in the recovery process. They need to understand why this is important for them. Otherwise, they're not going to do it. So again, we hammer them, say this is good for you, and they like it. Again, we've only had one person drop out of how many we've incorporated already, and they've been very happy. I think it's important for us to track my patients, to monitor my own surgical standards, and compare mine to global averages, and make sure I'm doing what's right. And it has other sides to teaching, so I can use it to teach my students, or other sides for practice. I can teach my students, I can put in journals, I can do the other things we already talked about. And more important, what's going to be coming is these large companies, as they buy more and more companies over, and they're going to be owning all these companies, is that if you have the data, my boss is at Harvard, said if you have the data, you can speak numbers, you can talk. It may not be perfect. You can't expect to be perfect. You can't expect always someone that says they have 100% healing rate for smokers for rotator cuff repair is probably lying. It means they haven't tracked the data, they haven't seen the revisions come back to their office. But to be honest, there's no way it happens, because we know even with the best rotator cuff repair in a healthy person, there's still a 5 to 10% failure rate. So that happens. So if we have the data, then you can tell people, hey, this is what I can do. Here's my skills. This is what I do, and here I have the numbers to back it up. I've been tracking it for this long, and I think that's where we're heading. We're heading to a place that when they're going to come, and especially when the government's going to come eventually and say, hey, we're only gonna allow certain people to do things because we can't, it's the drain on the system. You can only do a certain amount of things because of this. People that with the numbers, I think, are gonna go to the head of the line, and they're gonna be the ones that say, I can do this, and I can prove it, versus, oh, I did about 1,400 of these in my lifetime, and if you want the numbers to prove it anymore, then I don't think you're gonna be a valid resource. And next one, I think on a personal level, regarding shoulder arthroplasty, I think every shoulder arthroplasty should be planned. I really do. Every patient is a different patient. Everyone has a different pathology. The shoulder, unlike some of the knee and hip arthroplasty, which, and don't take it wrong for I completely respect my colleagues that do those, but they are more cookie cutter-esque. I think the shoulder is the most freely moving joint in the body. It allows it to do everything that you can want to do, and it's amazing. And to replace it, it has to take into consideration all the things it can do with the ability to hopefully not get to that failure part. And I think, well, I do know higher volume surgeons have better outcomes. So the ones that you want your shoulder surgeon to do 100 arthroplasties a year, you don't want them to do one. You really don't. Now, they may get lucky ones, but when you hit that curveball, you don't have that team member. When you have the experience of doing 100 or more a year, you have that ability to hit the curveball and say, okay, let's keep going, let's keep going with our day, as opposed to increasing your operative time, blood loss, infection rate, and all other bad things, exposure to anesthesia that exist when things don't go great. And I've always avoided conflict of ego. She's one of my, J.P. Warren, who's my fellowship professor, or fellowship director at Harvard, who's now, as a full-time orthopedic surgeon, is going back to Harvard Business School to go back and learn more about this. But he's a very prominent person in the American Academy of Orthopedic Surgeons on value-based care, and I talked to him a little bit before this, but avoid your ego. I think it's really important as surgeons, we all have them. I won't deny it. We do think we do things the best, but always be able to take a step back and look at the situation and say, hey, is there any way I can be better? And maybe you don't have to do it every day. Maybe do it once a month, once a quarter, hopefully more than that. But I do think that the outcomes don't let you really get away with it. So you can say, I do great in everything. You don't always do great in everything. So how can I make it better? So thank you so much.
I know we started a little late.
Oh,
Thanks, Kate.
so thank you for the talk. I'm interested, sort of, if you ever paying an RA in a private setting is comment on that, and it may not be an option that others would be willing to do, although you make a persuasive argument. But in the value-based care world, I think what sort of happened is there's been a lot more pressure for MAs and those kinds of staff to document directly into the EHR, and that creates a lot of problems. So I'm assuming that's sort of what factored in versus trying to just have existing office staff do this data collection for you, right?
Right, because if you do that, you won't have an existing office staff. They'll leave, they'll go somewhere else.
Because they just get frustrated. And then the quality of the data we've often wondered is compromised, sort of just checking the box
Right.
and moving through versus
Right,
having.
they have to process it.
Yeah.
It really, and that's what Dr. Warren, Dr. Higgins taught me. It has to be their only job. You can't have more than one job for this. To be a research assistant, that is it. Like, occasionally they'll help me put together presentations, look at the literature, search, not doing anything. But I mean, when I'm there, they're sitting there or standing, and we also try to stand and work. So we're sitting now, but we're there, and she is focused on it. Like, I mean, we'll laugh about something here and there, and lunch is lunch, but back to it, we're back to it, and that's it. I mean, straight. We're. And when I see clinic on Wednesday, we'll start at 7:30 and we'll go to 6, and half an hour for lunch, and we're going all day, and that's what they're doing all day. So now my bosses had 2 each, which is nice to be. So they had different roles, and they can switch back and forth. At this point, I don't need to do 2. And they were only shoulder surgeons as well. Their volume somewhere around the 500-600. I'm probably around 400 or 500. So am I close to getting a second one? Possibly, but we'll see in the future. But I really think it has to be their dedicated job. And it's unfair. I think it's unfair to the medical assistants as well to have that job. It's like you just said, that's my job. I need this patient out here. So I'm gonna, like you said, go through, and your quality of data may not be what you want or what you desire. I guess a lot of it comes in, you put in what you get out, or you get out what you put in. So you're going to give half that in, and you're going to get half out.
Yeah.
Yes.
Yeah, I just had a question more related to your patient's population. What type of age do you see most here?
So I see from around the shoulder, I do every single type of shoulder surgery. So I see even young kids. I had a 7-year-old clavicle fracture came in this week or last week, and then I take care of the oldest person I've done arthroplasty on is 96 years old. So She looked like she was 70, and she was gonna outlive all of us. So she looked amazing. I actually couldn't believe it. So I do everything in the shoulder, so all encompassing, all age groups. But
What's your majority?
so for shoulder instability, which tends to be a young person's game, that's usually 15 to 30, 35. Rotator cuff tears tend to be that 40 to 60, 65-year-old. And then the replacement total shoulders tend to be that 50 to 70-year-old. And reverses tend to be the 60 to 80, 85-year-old. Remember that rotator cuff is very important. There's a lot of people that could have a total shoulder at 80, but don't have a rotator cuff. So kind of those, we break it up. Yes.
And then, so you had it. It was impressive to see like 98, 99% compliance in terms of reaching out to the patients. So when the RA is reaching out, I suspect some of the patients may also bring up concerns that they have. How does that sort of tie back? Do they end up just going to the MA or to the nurse, or how does that sort of?
Right. So that's what they'll bring up, and then my RA or research assistant will tell the MA, or even tell me if I'm going in there right then. And they actually have write on a little sheet. So I still take each paper for one piece of paper on one for each room that I go into, so I can write my notes on there because I usually dictate. So I still dictate 20 people this morning. So
What about if they're reaching out to them after hours? Like how do they?
Yeah, they'll be messages. And also the cool part is if there is an issue. So say the patient's pain threshold is a standard deviation above normal, you get a ping email.
Oh.
And it tells you to call or suggest this patient has had this problem. So then my research assistant will originally reach out to them. And if it's an issue, they figure it out. They don't figure it out, then either me or my physician assistant will reach out to them. So, or bring them back in.
Yeah.
And say, hey, like my motion was doing great, and then all of a sudden dropped off. That scares me, especially in the setting of a rotator cuff. Maybe they had a failure. Maybe something happened. Maybe they got, who knows, the flu, which happens, and bring them in and see what's going on. Hopefully, usually it's not a problem. Reassurance is key. I love it.
And then, do any of the patients get frustrated with sort of the cadence of calls, especially, they're obviously involved with this, but then, patient experience and other things from the hospital or other, I don't know if there are other surveys that they're receiving.
I haven't found any problems. I can only dictate that because we have such a good compliance rate.
Yeah.
Maybe we're the first ones in. I don't know. Like if you're like the first one in, it's a lot easier to do it if you're the first guy in, as opposed to being the third or fourth survey.
Mm-hmm.
Yeah.
And that's possible. There could be survey fatigue, but these surveys really aren't typically long. Again, it's only a couple minutes.
Yep.
So it's not like you're going to click the 14th one, you're like another one, like some of the Christiana ones we get. Yeah.
And
Especially
they know it's tied to you, so
Right.
that if
and then
there's an issue,
and
if there's an issue, they can get to you
yes.
directly.
So,
So how do you handle, you said that you had IRB consent for each patient, and how do you handle IRB renewal and all the communication with IRB?
So
And which IRB do you use?
we have the one that we've standardized through our company. So we have a standard protocol, which I think is from University of Delaware. That's their standard IRB. Again, I can't really publish anything yet. We're only 9 months in, but we knew from the beginning that we had to have consent, HIPAA consent, and all that stuff done prior to we actually being applying for a project. So, but they have all signed the forms that pretty much allow us to do almost anything.
But you have to renew your IRB every year,
Yeah.
right? So that's your research assistant who does that?
Yes, they take care of that stuff. I just sign a piece of paper. They're very good at being behind the scenes seamless, letting me do what I like to do, and they get to do what they're supposed to do.
Okay.
Thanks, guys.